So the global leaders is right now the largest ever made trial in PCI. And after the plateau, the FDA made an analysis of the relationship between ticagrelor and aspirin and realized that if you increase the dose of aspirin, the benefit of ticagrelor, this antiplatelet agent, disappear. That was on the website of the FDA. And then there was kind of extrapolation showing that you will have even better result if you eliminate the aspirin. So that was the reason to do the global leaders, is to associate ticagrelor with a very, very short period of low dose of aspirin. That was the concept behind. Because of course, dual antiplatelet therapy might be very good for the ischemic event, but might be very negative for the bleeding aspect. The trial design, it was a trial investigator-driven, so the industry is not behind. They have been grant giver, the AstraZeneca, biosensor, and the medicine company, but it is an investigator-driven trial. It's almost 16,000 patients who receive PCI. A mixture, it's an all-comers trial, so you have stable angina, unstable, non-STEMI, STEMI. All kind of lesion is authorized, and you can use as many stents as you want. And the stent by default was the biometrics from biosensor. Now the idea is to have one arm, the experimental arm, where you will use 1 month of aspirin, and then you will have ticagrelor for the next 23 months. So 1 month aspirin ticagrelor, and then ticagrelor as a monotherapy for 23 months. And that given to patients with acute coronary syndrome and stable angina. The other arm was the reference arm, and that's an arm where you receive clopidogrel and aspirin for 12 months, and then aspirin alone. If you have stable angina, if you have acute coronary syndrome, then you got aspirin and ticagrelor for 12 months, and then aspirin alone. That was the scheme of the two treatment arms. First, we have to say what was the primary endpoint, and the primary endpoint was extremely robust. It was all-cause mortality. All-cause mortality plus new Q wave on the electrocardiogram. So there was a huge core lab using the Minnesota code to look at these Q wave during the trial, pre-discharge at 3 months and at 2 years. And for the rest, it was all-cause mortality. And we are very proud because thanks to the investigate, but also public domain, municipal registry, national registry, we have only 8 cases where we don't know the vital status. So we know the vital status in 99.95%. That's quite remarkable in 16,000 patients. And the electrocardiogram assessment was also very good. Now, what is interesting is that we had also the BARC 3 and 5 for the bleeding. That's a safety issue. And what is interesting is that there was 2 landmark analyses, one at 30 days to see what will be the effect of removing the aspirin in the experimental arm, and then one at 1 year, another landmark analysis to see what is the effect of monotherapy ticagrelor versus monotherapy aspirin. Now, what is very interesting is that that trial is quote-unquote positive at 1 year. That means we reach a p-value of 0.028 with a risk reduction of 79, 0.79, very pleasant. But then what we saw the second year is that the adherence to the experimental treatment went down progressively, went down from 89% to 78%, while in the aspirin group, it stayed 89, 92, 93. So at the very end, and that's the end point, there was still numerically difference in favor of ticagrelor monotherapy, but we lost the p-value, became 0.072 with a risk ratio of 87. So we missed the boat for just at the very end. Clearly, if we had stopped the trial at 1 year, it would have been a highly positive trial. The bleeding side, the first years was very similar in both groups, and then in the landmark analysis in the second year also very similar. So at the end there was no difference at 2 years. It was around 2% in both groups of BARC3, BARC5. Yes, I mean, we have looked at very carefully. It is in the Lancet described in the table, but also in the supplement. In a ranking order of frequency, the first was dyspnea. We know that ticagrelor is responsible for feeling short of breath, and that was the reason for the investigator to stop. The second is that every time that something happens, even if the PCI were equal in both groups, about 9%, when there was a PCI, the investigator was not restarting the experimental arm. Instead of let the clock tick again, he didn't do it. Something similar for the bleeding. As soon there was a bleeding, no difference in bleeding, but so as soon there was a bleeding in the experimental arm, and they were not blind, the investigator were not blind, they didn't put back the patient on the experimental arm. That's the two key reasons. I think that, you know, the first time that we met to discuss this trial, that was in February 2011. Okay, every time I do a trial, it's 7 years of my life. Fortunately, they are superimposed. Otherwise, I would do just a few trials. But it took a long time. First, we want to eliminate completely the aspirin, and I'll tell you why. But we were quite cautious. I mean, it was premature in 2011 to say no aspirin. So we did 1 month aspirin. And I think that's one of the key message. I mean, you start to see a lot of trial with only 1 month of aspirin. What is unusual is instead of stopping aspirin, we stop aspirin and we keep the antiplatelet agent. Most of the time, it's sometimes the opposite. So that was the key difficulty at the beginning of the trial, is to convince the people that 1 month of aspirin will do it. You know, aspirin is a non-specific antiplatelet agent. He has his share of bleeding, GI bleeding. Yeah, that's for sure. And as I said, it is not specific. And in the meantime, the stent, which was with struts up to 150 micron, went down to 60 micron. So these struts get embedded quite nicely in the vessel wall, and the need for dual antiplatelet therapy for a long period of time is progressively disappearing. The question is, of course, is the ticagrelor the aspirin of the future? That's the other way to look at. Because don't forget, the reason why we give aspirin to all the patients with atherosclerosis is because in 91 in JAMA, there was a study with 87,000 nurses registered from US receiving aspirin and showing a reduction in acute myocardial infarction. We are still applying that rule in 2018. In the Lancet, which is going to be published tomorrow, at the time of the presentation, there is a forest plot at a certain point with 7 pre-specified subgroups. One is interesting. One is the individual above 75 years old, and they have a benefit, this group. You should never forget Valentin Förster is always saying that atherosclerosis is a process of aging. Yeah, of course we can also bleed, but bleed is most of the time iatrogenic, while the key problem is the thrombosis with the age. So that group older than 75 is benefiting in a significant way. And then, unfortunately, what we see in this trial is that, like many trials, there was a predefined analysis per geographic area. And obviously, the Western countries are doing better than the rest of the world of the old East country of Europe. I'm sure that you will see a lot of study where aspirin is kept only for 1 month. There are 6 or 7 in progress, so that's going to be a new trend. Personally, I've started a study where there is no aspirin called ASSET. We'll see. I mean, I don't think that we need this dual antiplatelet therapy. It's an old story, you know, for an old interventional cardiologist like me. I mean, aspirin was not enough. The stent was clotting all the time. So we need something. Anticoagulation was not the way to go. We try everything. And then came the ticlopidine, and the ticlopidine aspirin was the combination to get the stent open patent. And then ticlopidine was replaced by clopidogrel, prasugrel, ticagrelor, but the aspirin is still there.